So now we're going to talk about the bladder. So again, very similar to how I normally do things, we'll first talk about the imaging technique, the differential diagnosis to these bladder masses, and then really focus in on the bladder cancer staging aspect. So bladder cancers arise from the urothelial lining of the bladder. There are estimated 80,000 new cases in the US each year, causing 17,000 deaths. It's the fourth most common malignancy in men, and there are higher incidence in Western societies thought to be due to exposure to different types of environmental toxins. Bladder cancer risk factors include age. The mean age of diagnosis is usually in the 70s to 80s. As I mentioned, more common in men than women. And chronic inflammatory conditions such as chronic infection, indwelling Foley, that kind of thing. Carcinogen exposure, pelvic radiation, family history, and also Lynch syndrome. Bladder cancer can present with either gross hematuria or microscopic hematuria, or they may have irritative voiding symptoms. And these days, because we do cross-sectional imaging on so many patients, we may pick them up as incidental findings. I already showed this slide for workup of hematuria in the ER session, but just as a refresher, for patients who come in with microscopic hematuria, they really look for any obvious benign cause, such as recent infection, trauma, instrumentation, and so on. If there's no obvious benign cause, then they further risk stratify the patient. Low-risk patients will get repeat UA in 6 months or cystoscopy and ultrasound. Intermediate risk patients will get cystoscopy and renal ultrasound, whereas high-risk patients will go for cystoscopy and either CT or MR urogram. If patient presents with gross hematuria, because gross hematuria is associated with a much higher risk of malignancy than microscopic hematuria, they will proceed to work up with cystoscopy and CT or MR urogram. In thinking about CT versus MRI for the evaluation of bladder masses, there are obviously advantages and disadvantages to both techniques. CT is cost-effective, readily accessible, it's a fast acquisition, so very easy for patients to tolerate. And also we can show bladder calcifications very well. The obvious disadvantage is that the radiation dose issue, but a lot of the patients with bladder cancers are on the older spectrum, so radiation is less of a concern in that population. And the other main drawback is that the tissue differentiation is not that great. So from a staging perspective, CT is not quite as good as MRI. MRI has excellent soft tissue contrast, so it's great in the T staging, differentiating the muscle invasive versus the non-muscle invasive disease. Does not require ionizing radiation, and also it's safe for patients with chronic renal insufficiency or allergy to iodinated contrast. Main drawbacks is that it's very time consuming, it's expensive, and your technologists have to be really good with the MR protocol to make sure that you don't have a lot of artifacts, because otherwise it becomes very difficult to read. And we may overestimate the degree of bladder wall invasion after therapy. Next, let's look at the normal bladder anatomy. The bladder is located in the subperitoneal anterior pelvis. And the bladder trigone includes the 2 ureteral orifices superiorly and the urethral orifice inferiorly. The normal bladder wall should be uniform in thickness between 3 to 5 millimeters or less, depending on the degree of distension. Normal appearance of the bladder, so basically a very thin wall all the way around, and there's no asymmetric thickening or anything. And on the delayed phase, we see the contrast opacification of the bladder lumen. And when we look at the cross-sectional anatomy of the bladder, it can be divided into several layers. There's the mucosal layer, the submucosal layer that's in the peach color, the muscle is in red, and then the serosa in yellow. This becomes relevant when we talk about bladder cancer staging. With the protocol for our CT, we use the same CT urography protocol with the 4 phases. The arterial and the delayed phases go all the way through from the kidneys to the bladder, and they really deliver complementary information in terms of both tumor detection and staging. From the MRI perspective, it's mainly the T2s, the diffusions are really the workhorse. With the T2s, we also do small field of view, high-res images so that we can really look at that bladder wall very closely. Pre- and post-GAD images, and also a post-GAD, we would include the level of the kidneys also, so we get a nice look at for any lymphadenopathy that's up the pelvis or the retroperitoneum. Not all bladder masses are tumors, so there is a differential. We can get hematomas, but if we see a big bladder hematoma, obviously in the back of our minds, we also need to think about, is there a tumor hiding there that's causing the big hematoma? BPH can simulate the appearance of a bladder mass, and sometimes ultrasound or MRI can help you make that distinction and see how it connects to the rest of the prostate. This is a huge stone that basically has replaced the lumen of the entire bladder, so you can get really bizarre looking stones. And also inflammation. In this case, you have this very asymmetric bladder wall thickening along the posterior wall that may make you worried about cancer. So that's why they went on and did a biopsy. And it turned out to be cystitis cystica, which is a chronic inflammatory condition. So there is a differential for bladder mass. Now let's focus on the cancer side of things, because that's what we are most concerned about. So urothelial carcinoma is the most common bladder malignancy, accounts for 90% of the bladder cancers. They're typically avidly enhancing, and that's why bringing that arterial phase down to the pelvis is so important. On MRI, we'll see diffusion restriction, and they can have a whole host of different appearances with asymmetric irregular wall thickening, or they can be more focal with a polypoid or pedunculated mass. There may or may not be calcifications. Classically, we think about looking for that filling defect on delayed phase, but we can also appreciate it on the other phases. So this is a classic polypoid appearance of the mass. So here we see this mass that's intermediate T2 signal, as opposed to that muscularis layer that is very T2 dark. And I'll go over the staging aspects in a little bit. This is a DWI image that we show intrinsic, that we see that it's diffuse, it shows diffusion restriction. And then here on the post-contrast, some heterogeneous enhancement. So very classic look for bladder cancer. And once you see one bladder cancer, you also need to look carefully elsewhere because of the synchronous tumors. So here we have a big mass in the posterior right bladder that also extends into the right distal ureter. And if we look a little bit further, there's an additional mass that's coming off the anterior wall of the bladder. So just once you see one, look very carefully all around the bladder. This polypoid mass has some peripheral calcifications on the surface of the lesion, which sometimes you do see with bladder cancers. And this presentation is more of that asymmetric irregular wall thickening. So here we can see the right distal ureter coming in on the delayed phase. It's very narrowed at the orifice with this asymmetric irregular soft tissue thickening along the posterior bladder wall. And I like this case because it really shows how the arterial phase and the delay phase really complement each other. Normally, we are so used to looking for filling defects on the delayed phase, but honestly, it's very difficult to appreciate the asymmetric wall thickening along this posterior bladder wall. But whereas when you look on the arterial phase images, it's so much more obvious, these enhancing foci, so much easier to pick up on the arterial phase. So really you need to look at both of those sequences to maximize the yield. Same case on the coronal. So again, you can appreciate there is asymmetric wall thickening here on the delayed, but so much easier to pick up on the arterial phase. Next, we'll talk about bladder squamous cell carcinoma. It's the second most common type of bladder cancer, and the risk factors are chronic inflammation, smoking, and schistosomiasis. This is a case of squamous cell carcinoma in which you can appreciate that there is a big bladder diverticulum with multiple bladder calcifications indicative of that chronic urine stasis. And with stasis, the bladder is exposed to more of the carcinogenic chemicals and leading to the development of cancer. And then on the right lateral bladder wall, we have this polypoid mass with some calcifications along the surface. And then in this patient, he actually came in with contained bladder rupture, and that's why there is this collection along the superior aspect of the bladder. The third most common type of bladder cancer is bladder adenocarcinoma, and it frequently arises from the urachal remnants along the midline anterior-superior aspect of the bladder dome, and that's really the clue to the diagnosis. It can be mixed solid and cystic and may show some calcifications. Here is an example of the urachal adenocarcinoma. So in that very characteristic location, anterior superior aspect of the dome, so that's really the clue, because otherwise a lot of these bladder tumors, they look like each other. And then you also have some punctate calcifications. A different example in which now we have a more chunky calcification, but still, when you see a bladder mass that's along that very characteristic location, anterior superior aspect, think about urachal adenocarcinoma. The same case on the MR, and on MR we don't really see the calcification as well as we did on the CT. What we do see is that eccentric wall thickening, intermediate T2 signal with the heterogeneous enhancement. Again, the location is what's going to give you the diagnosis. Just want to briefly talk about bladder lymphoma. Primary bladder lymphoma is very rare, but we can get secondary bladder lymphoma in patients with advanced stage systemic lymphoma. The lymphomas we see in the bladder may be the mucosa-associated lymphoid tissue lymphoma or the MALT lymphoma, and are associated with chronic cystitis. Lymphoma, just like lymphoma anywhere else, can look like anything. So we can see them as solitary submucosal mass, multiple masses, or more a diffuse bladder wall thickening. Here's an example of a bladder lymphoma. It's a diffuse asymmetric wall thickening and also more focal masses. Can be very difficult to differentiate from the other types. I think seeing the systemic lymphadenopathy, the history, that's what's going to give you the diagnosis. And just to round out some more miscellaneous bladder neoplasms, this is a case of small cell carcinoma. So on the MRI, you can see this polypoid mass that clearly has invaded through the wall. And along the more superficial aspect, there's this non-enhancing component, that's the blood clot that's stuck on top of the mass. And small cell carcinomas are aggressive lesions, so patient already presented with lymphadenopathy at the time of diagnosis. In paraganglioma, this is an avidly enhancing bladder mass, and the classic history is that micturition syncope, in which when the patient voids, it causes the catecholamine release, and then it makes the patient pass out. So if they come in with that history, then it's likely a paraganglioma. You can also have tumors that arise from the muscle layer. So this is a leiomyosarcoma. This is a leiomyoma. It's very well circumscribed, so that's kind of a clue to the submucosal location of the tumor. And also conveniently, the patient has a bunch of fibroids that this leiomyoma looks just like the uterine fibroid, so it's typically T2 dark. As opposed to leiomyosarcomas, looks a lot more heterogeneous, like this example here. Heterogeneous signal mixed solid and cystic, aggressive looking. And then in the pediatric population, you can get rhabdomyosarcomas. This is a lobulated polypoid mass, and classically the description is that bunch of grapes appearance. But now let's focus our attention for bladder cancer staging. So the T stage is defined based on the depth of invasion of how far in the wall it invades. Let's come back to our schematic. So the TA lesions are non-invasive and are confined to the mucosa. T1 goes through the lamina propria into the submucosa, and TA and T1 are considered non-muscle invasive bladder tumors, and they are treated in a certain way. T2 and above are muscle invasive, and the treatment differs. So with T2, it extends into the muscle. And then with T3, it involves the serosa and goes into the perivesical tissues. And with T4, then you have involvement of the adjacent organs. End stage is fairly simple in the sense that N1 refers to single lymph node in the true pelvis, N2 with multiple lymph nodes in the true pelvis, and N3 refers to metastasis in a common iliac node. M staging is separated into M1A with the non-regional lymph node metastasis and M1B with other distant metastasis. So as I mentioned, TA and T1 are non-muscle invasive. So the first line of treatment is a TURP-BT, followed by perhaps chemo or BCG, depending on the risk factors. T2 and above are muscle invasive, and those patients would undergo neoadjuvant chemo, followed by radical cystectomy. Patients who present with metastatic disease will be treated with chemo. So now we got RADs for everything, and bladder is no exception. We also have VIRADs for predicting the likelihood of muscle invasion. Just like all the other RADs, it goes from a scale of 1 to 5, with 1 being muscle invasion highly unlikely, and 5 being muscle invasion highly likely. The things we look for are on MRI. We look at the structure features on the T2 weighted. We look at DCE, and we also look at DWI. It's a busy table, but I'll just highlight several things. So that low signal intensity line for the muscularis is very important, and that's why we really like to look at that on the T2. So if you see uninterrupted low signal intensity line of the muscularis, you're pretty good. You're probably in that VIRADS 1 and 2 range. And the other features that come into play would be the size of the lesion, whether or not the tumor has a stalk or is it a sessile mass. But really, I want you to focus in on that line for the muscularis. When you get to VIRADS 3, we don't have clear disruption of that low signal intensity line, but then there are other features that are slightly higher risk. When we get to VIRADS 4, we do get interruption of that low signal intensity line, indicative of extension into the muscularis. With VIRADS 5, we not only have the interrupted line, but we also have extension of tumor into the perivesical fat. So now I'll show you some examples. So in this case that I showed earlier, what is the T stage? So this tumor is pretty big, but on CT, frankly, it is difficult to resolve the muscle layers to determine how deep is the invasion. So patient went and got an MRI. So the muscularis is this low signal intensity line that goes all the way around. And even though the tumor is rather large, we can appreciate that this dark line looks preserved. It doesn't look like there's really any tumor extension into the dark line. And also centrally here, we can appreciate perhaps a stalk. So with those features, we would call it a VIRADS 2 lesion. The emphasis is the no clear disruption of the low signal intensity muscularis. And when they went in and resected the lesion, even though it is very big, it is a non-muscle invasive bladder cancer, a TA. Just to show you the example with the diffusion, so the bladder cancers tend to restrict, so you see them bright on the diffusion and then dark on the ADC. What about this case? So again, a rather large lesion, and when we look around on the CT, you get a sense that there may be a little bit of blurring of that perivesical fat, but it is a little bit tricky to try to stage on CT. So we got an MRI, and then again, we are looking for that dark line. And when we come across, we see that in certain places, that dark line is being interrupted and effaced. And that's why it's very important to get the small field of view high-res images so we can really appreciate the bladder wall anatomy. And then on this other slice here, again, you're looking for the dark line, and then here, the dark line is totally gone. And then we can see that there's tumor extending into that perivesical fat. And also helpful to look at things on coronal as well to get a different perspective. Again, following the dark line is being disrupted. So this is clearly a Virex 5 lesion with interruption of the muscularis line and extension into the perivesical fat. And it was confirmed that it was a T3 lesion on surgery. Just to show you the corresponding images on diffusion with nice restricted diffusion and the heterogeneous enhancement. And this patient already went through one round of TURBT with the diagnosis of bladder cancer. And then again, they want us to stage so that we can figure out what to do next. So here we do see those foci of enhancing lesions in the bladder. Maybe again, a little bit of irregularity of that perivesical fat, hard to tell. So then we went in and got MRI. So we see that exophytic mass, there's certainly involvement of that dark line. So you're already thinking that it's muscle invasive. And then also some irregularity going into the there's some irregularity, but that doesn't really look like necessarily that it's involving the fat. So sometimes these cases are tricky. And then when we look at the post-con, there's certainly some early enhancement, but the fat overlying it seemed to be okay. So we called it Virex 4 with interrupted low signal intensity line and early tumor enhancement. And again, it was confirmed a muscle invasive bladder cancer. And this example is a bladder cancer arising from a bladder diverticulum. It's important to mention that we frequently see cancers in the bladder diverticulum because of the chronic urine stasis, so that part of the bladder is exposed to the toxins for longer, so more predisposed to get cancer. And when you do get cancer in the diverticulum, because the wall is so thin, they tend to present at a higher T stage. So here we see this enhancing mass that's in the big bladder diverticulum. Looking at it on sagittal, it looks like it's maybe going into the fat again, a little bit hard to tell on CT. And when we look on the corresponding MRI, again, following the dark line, and then we can see this intermediate signal mass that's clearly gone through that low signal intensity line into the fat. And also when we look at the post-GAD images, we can appreciate that this mass, there's abnormal enhancement and abutment of the seminal vesicles concerning for involvement of adjacent organs. So this is confirmed muscle invasive bladder cancer with seminal vesicle invasion on pathology. This other example, when you first look at it, you may not even know that it's a bladder cancer. It is so exophytic. You may think that it's an adnexal mass. But when we look at multiple slices, we can trace that it is connected to the bladder and it's arising from a big bladder diverticulum. And on CT, we can appreciate that looks like it's abutting the uterus and also abutting some small bowel. So we're thinking that this is a high stage muscle invasive bladder cancer already. And of course, we just wanted to get the MRI for a better look at the wall. And we can, again, following what we see with the muscularis, we see clear interruption of the muscularis. And then also here is the uterus, and we can see that the mass is clearly abutting the uterus with loss of the fat plane between the uterus and the mass, and also it's abutting multiple small bowel loops. So we know that this is going to be a high stage. And also already coming in with lymphadenopathy. So not only is it muscle invasive, there's already lymph node metastases. So again, this would fall into that Virex 5 category, and this was again confirmed muscle invasive bladder cancer. You can also get metastatic disease with bladder cancer, obviously. Commonly, we see them in the liver, and when they occur in the liver, they tend to be hypoenhancing, such as this example here. And then we can also get nodes, not only in the pelvis, iliac chains, but they can go up the retroperitoneal nodes, and in this case, a big node in the portal habitus. And you also have implants on the colon. So you can certainly have to look very carefully at the usual places to look for evidence of metastatic disease. You can also get peritoneal carcinomatosis from bladder cancer. In this example, you can see multiple avidly enhancing lesions in the bladder, diffuse irregular bladder wall thickening, and when patient went for a PET scan, you can clearly see that there are all these FDG avid foci all along the peritoneum, and also abnormal FDG uptake within the pelvic nodes with metastatic bladder cancer. And as I mentioned earlier, these patients with metastatic disease will undergo systemic chemotherapy rather than surgery. So in conclusion, CT and MRI are commonly used modalities for the evaluation of focal bladder masses, and the management varies based on the disease extent. And MRI is very helpful in differentiating between the non-muscle invasive and muscle invasive bladder cancer. And the defining line is really in separating the TA and T1. Those are the non-muscle invasive disease in which patient will get a TURBT, versus the patients who have muscle invasive disease, the T2s and up, and those patients will undergo some neoadjuvant chemo followed by cystectomy. And with that, thank you very much.